Okay. So, good afternoon, teachers and respected teachers. So, today my topic is baroreceptor activation therapy. So, before going to baroreceptor activation therapy, so heart failure is defined as a chronic and progressive condition where the heart muscle is unable to pump enough blood through the body to meet the body's need for blood and oxygen. As it's a progressive disease, it gradually it decreases the quality of life of person and increases the hospitalization if you don't treat it. And by that time, it increases the morbidity and mortality of the patient. So to decrease this progressive disease, halt the progression and decrease the morbidity of the patient, various treatment modalities has come into action. Next. So among the symptoms which the patients present are the dry hacking cough, worsenings and shortness of breath.
Dr. Majumder, please a bit louder.
Okay. Hello. No, you
Yeah.
can hear. Yes. So it's mainly the fluid which gets accumulated in all over the body. If it gets accumulated in lungs, it's mainly the shortness of breath. If it accumulates in the legs and livers and all, it's increasing swelling of the legs, feet, and ascites occurs. Increasing body weight, which occurs at 2 to 3 pounds in a 24 hours or 5 pounds in a week, as well as trouble in sleeping, that is orthopnea. So 2 out of 4 people with heart failure die within 5 years. Next. So the treatment options which are already available is the medicines. The beautiful medicines, this is the ARNI, which is there, valsartan, sacubitril, ARBs, which were earlier there, and AC inhibitors, which are also present for a long time, the endocrine, lisinopril, and SGPT2 inhibitors like the empagliflozin and the dapagliflozins, which has been accessed as the class 1 indications. Beta blockers, of which carvedilol, metoprolol, and the bisoprolols. Diuretics are there, aldosterone receptor blockers, aldactones, or the Finrenon and Eplenon are there. The devices which are available are the defibrillators, cardiac resynchronization therapies like CRTP and CRTT, pacemakers, mainly the physiological pacings which has come into action, LVADs which are there. Next. So even after giving these treatments, in majority of the patients, we are unable to modulate the patient's symptoms because only 30% of the patients who have heart failure have indications for CRTPs, and majority of the 70% who are just struggling with EF of less than 35%, even after GDMT, is around 70%. With them, even we can try this new device, which is called the barostim or the baroreceptor activation therapy. Next. So what is the role of baroreceptor in heart failure? Baroreceptor plays a key role in modulating the autonomic nervous system. Baroreflex dysregulation can lead to autonomic dysfunction. And autonomic dysfunction is characterized by sympathetic overactivation and parasympathetic withdrawal due to the loss of the ability to exert sympathoinhibition. Is a central pathomechanism in the development and progression of several cardiovascular diseases, such as resistant hypertension, and heart failure. Therefore, device-based targeting the baroreflex system was suggested as a novel pathway to address autonomic dysfunction and restore the physiological autonomic balance in certain cardiovascular diseases. This is not a new concept. It was harbored in around 1965-70s. It was first defined when a neck surgery was being done, and then while being stimulating the carotid sinus during that one, bradycardia occurred. But after that, it was not being nurtured because many of the medical molecules were being processed. And after now, when the number of patients who are even after being in maximum of beta blockers or evapratins and all, we can't control the heart rates and finding because increased heart rate leads to further heart failure. So it's like a loop phenomena. So these baroreceptor activation therapy is now being nurtured and device being method wanted. So baroreceptors are embedded in the walls of the major arteries, veins, and heart and are activated in response to a rise in blood pressure and or volume. Arterial baroreceptors are present in the carotid sinus and aortic arch, activated mainly by an increase in BP. Cardiopulmonary baroreceptors are present in thoracic veins, heart activated mainly by an increase in blood volume. So activation of both arterial and cardiopulmonary baroreceptor inhibits efferent sympathetic signals to the renal, splanchnic, and skeletal muscle vessels, resulting in vasodilation. Only arterial baroreceptor activation results in activation of the parasympathetic pathway to the sinoatrial node, thus decreasing the heart rate. Next. So baroreceptor activation therapy was started and tried with spinal reflex activation, direct vagal nerve activation, but those two were not that successful. So baroreceptor reflex activation therapy is a device. This is a special device which consists of an implanted pulse generator, external programming system, and a leads placed adjacent to the carotid sinus to deliver electrical pulses to the carotid baroreceptors. This stimulation of the carotid baroreceptor results in activation of the baroreflex system with subsequent increase in the parasympathetic outflow and inhibition of the sympathetic activity. So this system consists of a 40 centimeter lead body that terminates in a circular backer 7 millimeter in diameter with a 2 millimeter iridium oxide coated platinum iridium disc electrode centered on the backer. So how it is being generated? So the pacemaker, the pulse generator is implanted subcutaneously in a infraclavicular chest wall pocket. Electrode implantation begins by surgically exposing the carotid sinus through a transverse cervical incision over the carotid bifurcation. The sinus region is then mapped by temporarily placing the electrode in various locations and applying electrical stimulation to determine the location with greatest sensitivity to BAT. So what are the indications? Left ventricular ejection fraction of less than equal to 35%, symptomatic NYHA class of 3 or 2 if there is a recent history of being in class 3, NT-proBNP of less than 1600 picogram per ml, no conduction abnormalities between ventricles, not indicated for CRT or not receiving adequate therapy from existing CRT device. Next. So is there evidence? Yes. Baroreflex activation therapy has been transmitted in has been done from 2016 to 2021 VTHF trials, and even in 22 our own expert analysis has been done with barostim baroreflex activation therapy. Next. This study in BEAT-HF trial, this study demonstrated the safety and effectiveness of baroreflex activation therapy in patients with heart failure with reduced ejection fraction. The objective was, this trial was a multicenter prospective randomized controlled trial, but was not a blinded study. Subjects were randomized to 1:1 to receive either BAT plus optimal medical therapy or the optimal medical therapy management group, the control group. So it was the enrollment criteria. The 4 patient cohorts were comprising of 408 randomized patients with HFrEF using the following enrollment criteria: that NYHA class 3 or functional 2, or who had a history of those 2 patients who had a history of functional class 3 in the recent past. Ejection fraction of less than equal to 35%, stable medical management for 4 weeks, and no class 1 indication for CRT therapy. Effectiveness endpoints were based on baseline to 6 months in 6-minute walk test in distance increase, Minnesota living with HF questionnaire, quality of life score, and terminal proBNP levels. The safety endpoint was included the major adverse neurological or cardiovascular system or procedure-related event rate, MANSI. Next. So initially, it was first randomization, which started from 2016, which was an adaptive trial, and then at data unblinded in October 2013. The patients were analyzed after 6 months follow-up, and around cohort A, which comprised of 271 with confirmatory patients of 137 was taken. But by that time, the hypothesis was articulated in November 2018, where NT-proBNP was sought to be less than 1600 picogram per ml for the patients. And then in 2018, cohort B was modulated. And then after FDA approval with design consideration in 2019, the data unblinded was confirmatory patients were taken. Next. So in B, the randomized 162 patients, of which BAT was given to implanted in 73 patients, and 6-month completion was done in 70 patients. And randomized C, the cohort C, among 102 patients, 57 were implanted with BAT and 50 completed the 6 months follow-up. So in cohort D, it was the combination of B, C, and it was totally 120 patients who completed the BAT with the follow-up of 6 months. while 5 couldn't be implanted with the bat, and 1 died during the procedure before being a follow-up, during the follow-up, and 4 withdraw during the process. Next. So it was found that exercise capacity, that is a 6-minute hall walk test, increased in around 60 meters in case of the bat with the medical management, GDMT patients, than those who were only on GDMT. While quality of life was significant improvement was there, and NT-proBNP, there was decrease of around 25% in the bat group. Next. So to conclude, the bat was safe and significantly improvement of quality of life, exercise capacity, and NT-proBNP was found. Because NT-proBNP is a good marker of heart failure management, and it has been given a level 1 indications for all heart failure management. Next. And which was included in this one. So even a cost impact analysis of baroreceptor reflex activation therapy in chronic heart failure patients in the United States was done. It was followed up for 3 years, and in the conclusion, it was think that BAT plus GDT treatment becomes less costly than GDT alone, beginning between 1 year and 2 years, and becomes less costly cumulatively between 2 and 3 years, potentially providing significant savings over time. Next. So it was this over which the cost analysis was done in a HFrEF patient, BAT with GDMT, if there was no major cardiac events or recurrent hospitalization or heart transplant requirement was less, CV deaths were less, and even LVAD requirement was less. And these were assessed from the BEAT HF trial as well as those which were available over the counter, over the period, those treatments. Next. So Barostim therapy, once it is implanted, it is during the implant procedure, it's a 1-hour procedure, and same day procedure, with low or no dose of therapy on that day. It is to be followed in 2 to 3 weeks, 1 to 2 months, 3 to 6 months, more than 6 months, and the battery, it lasts for around 5 to 6 years. So gradually the therapy and the doses of the drugs to be titrated accordingly. Next. So it was vagal stimulation, which showed that did not result in significant improvements in objective endpoints of decrease in systolic volume, reduced heart failure hospitalizations, or cardiovascular mortality. So vagal stimulation, which was shown in Innovate heart failure trial or the Nectar-18, was not at all successful. While in the BEAT HF trial, BAT improved 6-minute hall walk test distance, quality of life, and the NT-proBNP. Though in this trial did not assess the left ventricular structure or function, and the post-market phase, it will assess the morbidity and the mortality. So preclinical and early mechanistic clinical studies that used BAT suggested that because carotid baroreceptor stimulation resulted in an efferent signal processed in the brain, a balanced reduction in sympathetic activity coupled with an increase in parasympathetic activity. This rebalancing of the abnormal sympathetic and or parasympathetic tone in HFrEF is a novel aspect of BAT. Next. So to conclude, heart failure is a progressive disease affecting a large population. Adequate and appropriate goal-directed medical management and various devices have made life much easier. Barostim Neo is a new game changer in the treatment of heart failure. BAT is a safe and effective device for majority of the heart failure patients. It is also cost-effective in long term. Next. Thank you. As this heart failure symposium is going on, this is water all over, and we are trying to build up more and more bridges over it and try to tide over this water. Thank you.